Halo Sobat Espos, berjumpa kembali dalam Solopos talkshow virtual bersama dengan Dr. Yuh Shan dari Parkway Cancer Centre Singapura. Nah, kali ini kami akan berbincang tentang metode baru untuk kanker darah. Dan tentunya Sobat Espos, seperti kanker pada umumnya, kita tahu bahwa untuk proses penyembuhannya biasanya menerapkan metode-metode seperti kemoterapi, kemudian cangkok sumsum tulang belakang, ada juga konsumsi obat untuk menghambat pertumbuhan sel kanker. Tapi ternyata sekarang ini sudah ditemukan sebuah metode untuk pengobatan kanker darah. Namanya adalah Car T-Cell Therapy. Menarik ya, karena saya yakin semua hal yang berbau ataupun berbincang tentang kanker ini akan menarik untuk diulas. Apalagi untuk menyembuhkan pasien-pasien yang memang didiagnosa kanker, dalam hal ini adalah kanker darah. Nah, kali ini saya Nur Atmaja akan mengajak Sobat Espos semuanya untuk membedah apa itu Car T-Cell Therapy. Ada Dr. Yuh Shan dari Parkway Cancer Centre Singapura yang akan membedah nanti apa itu Car T-Cell Therapy.
Thank you. Thank you for inviting me to share a little bit about this CAR T-cell, especially for the Solopos Media Group. Okay, I'll start by sharing some screen presentation. Should I? Or
before you share your screen, can you explain what is blood cancer?
Oh, okay. Yeah. So blood cancer can be divided into three main subgroups: the leukemia, the lymphoma, and multiple myeloma. These are the three main subgroups. Okay, now, who can be affected by this blood cancer? It's actually all age group. Leukemia can happen in the young children up until the elderly population. So you have actually two spikes. And the lymphoma actually in the teenager, they can be affected by this Hodgkin lymphoma. And then at the elderly, about 60-something, Hodgkin lymphoma is also prevalent. And the rest of the group, usually in the middle age group until elderly, more commonly to see the other types of lymphoma. Multiple myeloma is a disease usually you can see in the elderly population.
Apa sih yang menjadi penyebabnya? Kenapa anak-anak yang lebih banyak diserang untuk kanker darah ini?
Okay, so the young children has higher risk of getting this acute leukemia, but it's actually very well, the outcome of treatment is very good. Of course, unfortunately, we do not know the exact cause for the development of this acute leukemia in the young population. Some of it may be genetically related, but the risk is not like a conventional, like a breast cancer. The genetic risk is that high. A lot of time it is unknown for this acute leukemia in the children population. Okay, I'll start sharing the screen.
Yang dimaksud dari Car T-Cell Therapy, silakan dokter.
Yeah, thank you very much. So we'll talk about the CAR T-cell. This is a breakthrough in the treatment of blood cancer. Okay, why I say so? So we know that blood cancer is actually one of the most dreadful cancer. At this cancer can happen suddenly, and potentially, if you don't treat well, it can be deadly. And in general, as I explained before, it can be divided into three main subtypes: the leukemia, the lymphoma, and the myeloma. And CAR T-cell actually is a new milestone in the treatment of this cancer, and actually revolutionize how we treat this deadly cancer.
Dokter, kenapa sel T tubuh kita ini tidak bisa mengenali dan juga menghancurkan sel kanker tanpa harus dimodifikasi terlebih dahulu, dokter?
Okay, yeah. So can you explain that? So this is a blood cancer which I explained previously. Now, why using the CAR? What is CAR T-cell? CAR T-cell is an abbreviation for chimeric antigen receptor T-cell, CAR. And this is a genetically modified the patient's own T-cell to direct the T-cell to attack tumor. So why use T-cell? T-cell is actually a key in the immune defense in our body. As compared to B-cell actually secrete antibody and destroy the cell from outside. CAR T-cell, the T-cell is actually very effective to destroy any and the tumor or any infection from the inside. As shown in this diagram, actually, the T cell, it can divide into CD4 and CD8. So the this T cell will recognize the antigen presented by tumor, and then they'll secrete all these chemical called cytokines to attract more T cell and more immune cell to actually attack the tumor. At the same time, we have when they are, and all this CD8 T cell is near to the tumor, they'll release more of the chemical we call cytotoxic chemical to go into all this infected cell or the tumor cell, and they will break it away. However, all these T cells, they are not very specific, and they cannot recognize the tumor very well. So by genetically modifying, we can actually direct the T cell to attack the tumor more effectively than using a normal T cell alone. Now, shown here is the animation of what we meant. So we have on the top side here, we have a tumor expressing the CD19, which is what most of our CAR T cell is based with. And on the bottom part here is the CAR T cell. So the idea behind this CAR T cell is that we collect the T cell, we modify this T cell to be able to express this receptor against the antigen, which is against a target. And then by modifying this, all these T cells being educated, they enhance the immunity, almost like a smart bomb like that, to direct these live missiles to the target, the CD19 tumor cell. This is shown here is the journey of CAR T cell discovery until clinical approval by the FDA. It took about 25 years, a long time, and there was a hiatus in between because of the development of other drugs. And finally, in 2017, we get the approval to use this commercially in the States. And finally, for the past 1 year, we managed to get this available in the private setting in Singapore. Okay, shown here is many different generations of CAR T cell, first up to the 4th generation. And the difference in the design is mainly you can see, from one green color to many more colors. The idea behind this, all these are the anchor protein. These are the ones that actually make the CAR T cell more sustainable and more active. And the 4th generation, of course, they may be made like enhanced missiles. They can secrete all these things called cytokine, so to be able to attack the tumor cell more effectively. Currently, what we can offer is the 2nd generation CAR T cell, which is quite efficacious. So shown here are the many different CAR T cell. What's important is a very busy slide, but it's important is this one. And what are the approval status? So it's approved to be used in diffuse large B-cell lymphoma, acute lymphoblastic leukemia, and one of this is being approved for the mantle cell lymphoma as well. So mainly the B-cell lymphoma and the acute lymphoblastic leukemia, B subtype. Shown here are the landmark article regarding the acute lymphoblastic leukemia as well as diffuse large B-cell lymphoma. So how to use this CAR T cell, when to use? I think it's important for us to have a overview of how we treat patient and how this CAR T cell will fit in. So for patient having acute lymphoblastic leukemia, we will start the treatment we call induction, and then we will continue to assess the patients after induction and for the need for transplant. So need for transplant, we look at the genetic risk and the response to the treatment. And after that, we may consolidate further to reduce the burden of leukemia. And finally, we go for the allogeneic stem cell transplant, which potentially can offer a curative methods to cure the patient from acute lymphoblastic leukemia.
Dr. Lee, kalau T-cell ini berpengaruh ataupun menyebabkan kanker darah, apakah berarti ada sel-sel lain? Kalau tadi saya melihat di slide Dr. Lee ada sel B atau sel-sel yang lain. Ini apakah juga ada kemungkinan kalau dengan sel yang lain ini untuk jenis kanker yang lain juga, Dok?
Actually, it's very good questions. That's why I show that the treatment for this CAR T cell is only for B, acute lymphoblastic leukemia, and for T, acute lymphoblastic leukemia. So this is where the difficulty is, because if you use the target in one of the T cell target, then they may kill off their own CAR T cell. So this is an area in need where other cell being used, such as NKT cell, being explored, and CAR T-cell specifically targeting those more finite antigen, like CD5 or other antigen, are being explored in clinical trial. So until those result or the result of the trial be more convincing, currently we can use this treatment for CAR T only for B cell.
Kalau boleh tahu nih, kanker apa saja sih yang bisa diobati dengan metode CAR T-cell method?
Yeah, so currently we have a treatment for the B cell, aggressive B cell, and some of the CAR T-cell treatment is exploring into using this for less aggressive, we call indolent B cell lymphoma. There are, of course, other things that may work is all this, what they call that, multiple myeloma. And AML is one of the area or the field that the CAR T-cell is trying to explore as well. So it's continued to improve, but the most robust data currently is for B cell and B cell aggressive lymphoma, as well as acute lymphoblastic leukemia. But in the near future, I'm quite sure we can see more evidence and better data in other fields as well. Okay, so I will continue how we actually treat this acute lymphoblastic leukemia. Shown here is the left-hand side is efficacy of using immunochemotherapy and transplant, and you can see the efficacy is improving over the years, and you can reach almost like 80-90% survival rate. However, for those patients who relapse, the survival rate is very poor. The 10-year survival probably are talking about only about 10%. So when we should use CAR T-cell in B acute lymphoblastic leukemia is here. Okay, when patient relapse, you try to give chemo again to achieve good control. And if not good control, further chemo. If good control, we attempt another transplant again. So if not in good control, this is where the CAR T-cell can fit in. So shown here is the efficacy of one of the CAR T-cell, under ZUMA-3 trial. And you can see that, for those patients who responded, the survival actually, you don't reach, the continue to improve further. Of course, if you look at all patients treated, it's also not too bad. The efficacy is quite good, and the median survival is median overall survival is at least 2-something months. But these are the one, the overall, 2-something years, 2-something months. If you look at overall picture, actually this is still better than the curve that we see just now is like very, very low kind of survival. And we know that the CAR T-cell also can survive very long in the body. And so with this kind of interim result, actually for heavily pre-treated, this is quite exciting and efficacious. The all patient is at least 18 months survival.
Kapan sih CAR T-cell ini bisa digunakan oleh si pasien? Apakah misalnya nih setelah terapi lain tidak berfungsi dengan baik ataupun tidak bekerja dengan baik, atau justru sebelum kita ke terapi-terapi yang lain, kita ke CAR T-cell dulu nih. Nah ini seperti apa nih, Dok?
Yeah. So as I shown before, usually patients, if they relapse, you try to use a conventional chemotherapy and whether can do another transplant. If the patient doesn't respond, it's a clear indication we should do this CAR T-cell. However, for those patients who responded, we should just follow the conventional way, give them another chance with the CAR T-cell, with the conventional transplant. However, I think in the near future, we'll move towards CAR T-cell earlier as compared to using the conventional treatment methods.
Kabarnya, setiap pengobatan kanker ini menyakitkan, dokter. Entah itu kemoterapi ataupun sungsum tulang, cangkok tulang belakang. Tapi untuk CAR T-cell ini apakah juga cukup menyakitkan, atau justru ini lebih nyaman untuk si pasien, Dok?
Okay, so the conventional chemotherapy transplant, we know all the traditional side effects, like nausea, vomiting, hair loss, graft-versus-host disease, which I'm going to explain later. So CAR T-cell has less of these side effects, and in fact now in between production of CAR T-cell, there are some new trial that say that you don't have to give anything, give some gentle treatment, some radiation, they actually reduce the side effects. But of course, CAR T-cell has their own side effects, which I'm going to explain later as well. But in general, I think this is compare overall is less side effects as compared to the conventional chemotherapy and this what do you call that, allogeneic stem cell transplant. Okay, so I just talked a little bit on I finished explaining about leukemia. So it just shown you how we treat aggressive lymphoma. So usually once have aggressive lymphoma, we give chemotherapy, usually about 6 to 8 cycles. And after they go into remission, we just observe, and only in very, very specific type of aggressive lymphoma, we'll do autologous stem cell transplant. And we aim for cure with that kind of approach. But some patients also relapse. So what happens when they relapse? We'll give salvage chemotherapy, means we try to save them again, salvage, okay? And if the patient responds, we'll do the autologous stem cell transplant, means using patient's own stem cell. And with that, if you go into remission, we'll just observe the patient. But if patient relapse after the stem cell transplant, we give chemo again and try to aim for stem cell transplant using other people's one. And for those patients who after the salvage chemo didn't respond, you give more chemo again, and we aim to transplant using other people's stem cell. So CAR T-cell will fit in when patient already failed at least 2 lines of treatment, and this is where you use CAR T-cell. And why do we say so? It's because we know those patients who have multiple lines of treatment, the overall survival is only 6 months. Okay, very short. But if you use CAR T-cell, shown here is one of the CAR T-cell that we have. And you can see the survival, about the 2 years is still about more than 50% of them will respond. And duration of response after this follow-up of about 3 years is about 59%. So most of the patients survive longer than the conventional 6 months. So hence this CAR T-cell has been proven to be more effective in the patient who have relapsed refractory disease.
Tadi disebutkan bahwa ada kalau misalkan tidak bisa setelah pengobatan tidak bisa dengan menggunakan sel sendiri, maka akan digunakan sel orang lain. Nah, ini apakah bisa sembarang orang asal cocok atau harus keluarga nih, dokter?
Yeah, so the donor usually try to find from the family members because the chance of finding a matched donor. When we talk about matched donor, we look at the gene, mainly we call HOA typing, HOA gene. And if the HOA gene is matched, then that will be the best donor. So a good question also, from autologous cell sendiri to the allogenic from other people, what is the difference? And these are the conventional way how we treat patient using transplant previously. So autologous means usually use patient's own stem cell. I can see here, we take the stem cell from the blood, and then we go and store the stem cell. When the patient gives chemotherapy, all this thing in ready, then we give the patients back only the stem cell to the patients. Okay, so this is how we do autologous stem cell. But this is only effective for those patients who respond to chemo. So means you are responding to conventional chemo, we give you a stronger dose of chemo to kill off all and use the stem cell to rescue the marrow. Now for allogenic stem cell transplant, we use other people's stem cell, okay? And this stem cell, actually, when they grow up, they can be the immune system, like a policeman like that. If they see any of this tumor, they will attack them. But allogenic stem cell transplant comes with a cost. And these are the side effects: the chemo, the radiation side effects, the graft versus side effects, and the risk of infection as well. And this graft versus host side effects can be quite debilitating. It can attack the organs like the liver, the gut, the skin, and sometimes you can see patient having other complications as well in the lung. So CAR T-cell, they use patient own T-cell, then they can avoid the complication like graft versus host disease using other people's stem cell. And we can actually target, we say about immune surveillance, but using CAR T-cell, we can train the T-cell so that they can target the tumor more effectively by doing this genetic modification. And once we actually genetic modify them, we can expand the army, we can expand this cell and infuse them back to fight the cancer. And the good thing about this blood cancer as compared to other solid cancer, blood cancer is liquid. So they can avoid most of the tissue problem, like most of the issues such as the penetration of the CAR T-cell, the tumor microenvironment, the tumor suppressing cell around the tumor. So that's why this blood cancer cell is the most most effectively treated with the CAR T-cell.
Nah, dokter, apa sih sebenarnya kalau tadi kita ngobrolin soal resiko bagi si pasien begitu ya. Kemudian untuk resiko bagi pendonor apa nih, Dok? Dan sebenarnya apa sih yang diambil dari orang lain? T-cell ini apa sih bentuknya? Apakah bentuk dari darah atau apa kandungan dari darah merah atau apa sih, Dok?
Okay. CAR T-cell is from the own patient. It's almost like a normal white cell we call lymphocyte. So from there, actually, we can take, like how we shown here, we can take the T-cell from the patient, just like how we donate the blood. But now we can, the machine is very advanced nowadays. It's almost like a dialysis machine, but we can actually tune it so that actually we only collect the white cell and you return the red cell, the platelet back to the patient. So that's how, all this blood bank can actually take the platelet donation currently. So this is how we collect the T-cell. And if you talk about the, the donor for allogenic stem cell transplant, usually for the donor, they are healthy. And with the risk for the donor should be 0. So which is why we always screen the donor for the allogenic very strictly. And then there's a few criteria. It's almost like a blood donation. We also need to do a lot of virus screening. We do the chest x-ray, we do an ECG, make sure the patient is well before you can approve the patient to be a healthy donor. So the risk for the patient is very low and we don't expect long-term side effects. So shown here is how we actually collect the T-cell, the production of CAR T-cell. As I said, we collect the T-cell, the blood is from the blood. We don't have to do the bone marrow, don't have to go to operation theater. We just put in a needle here, then we can use the machine to collect the T-cell, all the white cell, we can separate it out in the lab, and then go to the lab, we make the CAR T-cell. They insert the gene, we call genetic modified it into the T-cell, so that when the T-cell grow up, they can express, because of the gene, right? They can actually produce this receptor on the surface of this T-cell. This is what we call genetically modifying them. And actually we grow it, from this 1 million, we can grow it 3 million or so. So we grow enough so that it can be infused back to the patient. And after the cell is back in the body of the patient, the same patient, so this T cell, we recognize the cancer cell or the, the leukemia or the lymphoma because of the receptors. You direct the T cell to attack where we want them to attack. That's why the CAR T cell is different from the conventional autologous and allogenic stem cell transplant.
Oke. Dokter, apakah ada pola makan tertentu, pola diet tertentu untuk bagi pasien ataupun bagi pendonor sebelum melakukan CAR T-cell ini, Dok? Misalkan untuk pendonor harus banyak makan apa dulu supaya kandungan T-cellnya ini banyak, sehat, atau seperti apa nih, Dok?
Okay, I think I need to differentiate. So for CAR T-cell, the pendonor or the one who donate and the patient, they are the same person. Okay, that's why we say the CAR T-cell is autologous from the same patient. So if the patient is healthy, we deem the patient is fit, right? They should just eat the normal food, healthy food, balance. Don't have to take additional food. Okay, that is good enough. Yeah. So when patient come for CAR T-cell, right, or refer for CAR T-cell, what do? We have to evaluate the patient, make sure we confirm the diagnosis is indicated, the relapsed acute lymphoblastic leukemia or lymphoma, right? Then we have discussion among ourselves, among in the transplant meeting about the patients, whether they are suitable or they are acceptable. Then we will start to extract the T-cell, and this T-cell, after we extract it or we collect it, we'll send to the lab for genetic engineering and expansion. And finally, when it's ready, we will give the patient some chemo so that to prepare the body to accept this CAR T-cell, and then we infuse that. So the timeline from the patient starts from the first day we see the patient until they receive the CAR T-cell, usually takes about 3 to 4 weeks. And after a patient receives the CAR T-cell, we will observe them in the ward. Takes about 2 to 3 weeks before we actually allow the patient to go home.
Yeah.
Why we need to monitor the patient in the ward is because of the adverse reaction, and this is what we say. I will talk about the adverse side effects from the CAR T-cell. So all the treatment, regardless of chemo or new treatment, have their own specific side effects. So you can see that these are the common side effects we call CRS, means cytokine release syndrome. I will explain further. And the neurological events or neurological side effects that we need to monitor closer as well. So usually we try to do this as inpatient, until we have a better CAR T with the less side effects, then we may start to do this as outpatient. So from the time the CAR T cell is infused, the onset of this cytokine release syndrome, which I explained what it is about from day 2. And then it takes about 7 days to settle. But among that, we have other things that can happen, the neurological side effects, about on medium time of onset, about 4 days, about 21 days. These are the timeline. So usually try to observe the patient in the ward or some facilities close by where the patient can come for monitoring closer. We also need to consider, before the CAR T cell, we give a bit of chemo. So the white cell count will be low, and we need to make sure the patient white cell count recovers before the patient is eligible to go home.
Oke, dokter, apakah bisa CAR T-cell terapi ini dikombinasi dengan terapi yang lain, dok?
So CAR T-cell is a new treatment and is very effective. So we usually try not to combine together because then we do not know, the side effects come from other medication or from the CAR T-cell itself. Okay, yeah. But if you look into how the CAR T-cell develop in the near future, okay, not very long, we are using CAR T-cell in combination with the other immune medication, like all these checkpoint inhibitors, to enhance the efficacy of this CAR T-cell to make it more prolonged and more efficacious. But that's in the near future. Currently, I think to be very clean, we just use CAR T-cell separately. Okay. Yeah, so we talk about cytokine release syndrome or CRS. So these are the specific side effects from this CAR T-cell treatment. Basically, it's like a patient having very bad infection, and all the chemical or this cytokine being released. So as you remember, I showed initially, the T cell, they are known to release this cytokine, and these are the ones that cause the body to have commonly like fever and the heartbeat very fast, and the patient may have a low blood pressure, like having shivering. This is a systemic kind of reaction, and that's why it can affect multiple organs. But we are recognizing this kind of side effects, and we even have all this grading, different grading, and how we are actually going to treat this patient. Of course, more of the serious side effects are your heart beating irregularly, going to heart failure, having some kidney injury, and low BP, all this persistent low white cell count. These are the potential side effects as well. So shown here is how we manage cytokine release syndrome. As I said, this is like almost an international standard. We know the different grading, like grade 1, 2, and 3, what we need to do. And those like more low grade fever, we can always treat with some paracetamol. And then those that are having a higher grade, like need oxygen or low blood pressure, we can have other medication. We call that tocilizumab, which is IL-6 inhibitors, which is one of the key treatment for cytokine release syndrome. Apart from that, sometimes we also use steroids. Yeah, so all these cytokine release syndrome, they are temporary and should resolve before the patient is discharged. And it's just during this hospitalization, and it should resolve without any long-term side effects.
Ya. Dokter, ada nggak sih kondisi khusus bagi penderita untuk mendapatkan terapi ini? Misalnya ada batasan-batasan usia tertentu, kemudian kondisi-kondisi tertentu, begitu. Ada nggak batas-batasannya?
Yes, yeah, we do have a certain criteria. That's why we need the patient to come down to assess. Interestingly, for the age per se, so far, CAR T-cell, there's no age limit. But we also need to make sure, the patients have enough kidney function and the lung and the heart. Because, as I showed, the patient may have all these other side effects, cytokine release syndrome. We must make sure their organ can handle all these side effects if it happens. But apart from that, currently, based on the label, there's no real cutoff for the age, but we always have to assess the patient individually, and more importantly, is all the other organ function. So now we talk about another important side effects, which is what you call immune effector cell-associated neurotoxicity. A long name, basically, is a side effects affecting the brain and the nerve. So the common side effects is patient may have all this, seems like a little bit drowsy, may have tremor, and usually when we ask the patient, we make sure the patient handwriting is the same consistently. When you see a little bit like abnormalities, then maybe patient having some great abnormalities of icons already, and the serious one, they may have even like confusion. And if this thing we don't stop it early with all these steroids, patient may have things like seizure and may have become like very sleepy most of the time and can't even answer properly. So the same thing, we have different grading for these icons, and we have different management kind of situation, of course, such as management strategy like using steroids, using all these IL-6 inhibitors as well. So again, these are the well-known side effects, and we have different things or different grading how we manage all these side effects.
Oke, Dok. Biasanya dalam satu kali terapi itu butuh berapa waktu sih, Dok? Berapa lama misalnya untuk satu kali terapi CAR T-Cell ini biasanya membutuhkan waktu sampai selesai seminggu kah, 2 minggu kah, atau 2 hari kah? Atau mungkin dari beberapa pasien ini harus melakukan CAR T-Cell ini setiap berapa hari sekali? Seperti apa, Dok?
Okay. From the time patient come until we can give is about 3 to 4 weeks, and after that we give one treatment and patient stay for 3 weeks to 4 weeks, and patient only need one treatment, cuma satu, just one CAR T-cell, and then we assess the efficacy, and monitor the side effect. That's all. If go into remission, we just monitor from there. If there's still some residual disease, we may use a radiotherapy to kill it off, but only one CAR T-cell infusion. Okay. Now I'll talk a little bit about this future of CAR T-cell. So there are 2 or 3 trials, challenging, as I showed before, how we treat large cell lymphoma. You give chemo, if a relapse, you use a stem cell transplant, autologous stem cell transplant. So these 3 trials is comparing CAR T-cell versus autologous stem cell transplant. And if you look at how we treat for patient having a relapse, and this one is challenging the conventional relapse, patient who relapse within 12 months or never go into remission. So where are they going to challenge is here. They are going to move the CAR T-cell earlier. After salvage, you give stem cell transplant, autologous or CAR T-cell. And this is what the 3 trials is talking about. And maybe we'll interpret first. So shown here are the 3 results, okay? 3 trials. 2 out of 3 show efficacy, okay? EF means benefit, as compared to autologous. But what is important is this one, okay? The time of infusion means from the time we collect until the time we give back to the patient. You can see those effective one, positive result, very short, 26 to 31, means within 4 weeks. But if you prolong more than 6 weeks, it doesn't show that effective. I think in between, a lot of patients drop out. That's why I think this trial doesn't work because of that. Means the faster the pharma can produce this CAR T-cell and give back to the patient, the more efficacious this CAR T-cell will be. And shown here is one of the results as compared to standard of care, which is transplant. You can see the curve. This is transplant, the black color one. But if you use CAR T-cell, the beige color one, you see, this is what you call no event, means the patient survived without any relapse. It's definitely better than conventional stem cell transplant using autologous. And the story continues, So now this another trial called Zuma 12. They are even challenging the frontline chemo. As you can see on the left-hand side here, the high-risk disease like, this double or triple hit lymphoma. After 2 cycles, if patient shows some progression or not, positive PET, no disease hasn't gone into very good remission yet, not even have to go into full remission, and then they go and do CAR T-cell. And interestingly, you see the response rate is very, very high, almost 90%. And this is what you don't see when you continue the patient having this high-risk disease using the chemotherapy alone. So this trial is going to push further and for the role of CAR T-cell in the treatment of lymphoma. Oh, it's definitely. So conventionally, if you look at this triple hit or double hit, if they don't respond, so after 2 cycles, usually they do very poorly, and most of the time we cannot even salvage the patient back. And these are the ones very challenging. So you can see this response rate almost like 89%. It's actually quite impressive. So I show you all that the CAR T-cell, the faster you can give back to the patient, the better. So the next thing that's or next improvement in CAR T-cell is off the shelf. Means you want CAR T-cell, you just order, then you come. So the timeline will be shorter, not even like 4 weeks, 3 weeks. It's only like 1-2 days, then you can give the CAR T-cell. This is what we call allogenic CAR T-cell. Means you already prepared this CAR T-cell from using other people's T-cell. They have the way to actually modify it so this CAR T-cell will not cause any harm. And you just have to take it off the shelf. This is the next development milestone in CAR T-cell so that we can actually reduce the timing. Patient 1, you just order and it'll be available. Yeah, instead of waiting for 3 to 4 weeks, to production, then patient like waiting there. Of course, anxiety, waiting for all these things. It's very fast. You just order, it'll be available. But this is the future, and this is where the CAR T-cell research is going forward in allogenic stem cell. And allogenic CAR T-cell means you just buy, order, and like a drug like that, it is available already.
Oke.
This is the future.
Seperti donor darah beneran nih, Dok ya?
Yes, like a medicine you buy from the counter like that. But of course, had to go through.
Yeah.
So in CAR T-cell, of course, development in other, blood cancer as well, like multiple myeloma. Shown there are many different CAR T-cell available. In fact, some of the CAR T-cell may already be approved by FDA to be used for patient having multiple myeloma. So from leukemia, we have lymphoma, we have myeloma, all we have been covering with this CAR T-cell. So those high-risk diseases, in fact, you use CAR T-cell, we may be able to overcome the resistance for that. But it's still in development, and we hope to have this soon in Singapore as well. So CAR T-cell, involve, have to emphasize that, it is not a one-person kind of a job we can do. Involve many logistic, multidisciplinary approach from, the consultation, the various nurses, the logistic from the hospitals, the nurses support as well, and all this lab to process the stem cell. So it's a multidisciplinary approach, and you can do it only with a team approach. Okay. So has shown that the CAR T-cell data, so it's really effective and maybe life-saving in relapsed refractory large B-cell lymphoma and acute lymphoblastic leukemia. So of course they have their own side effects, but these are most of the time manageable. And we have more roles in other types of blood cancer like multiple myeloma, maybe T-cell acute lymphoblastic leukemia in the future. And of course, I think this is the future for cellular therapy of blood cancer. And as I say, it involves many teams, and it takes a whole group to be able to set up this CAR T-cell delivering to the patient. And then we are proud to actually be able to offer this CAR T-cell to patient.
Okay. Satu pertanyaan terakhir, Dokter. Untuk terapi ini, bagaimanakah dengan biayanya, Dok? Mengingat kalau dibandingkan dengan pengobatan-pengobatan yang terdahulu, ini jauh lebih simpel, jauh lebih singkat begitu.
So, you're right. The previous treatment is, a shorter duration of treatment, and the cost, of course, is a bit lower as compared to the current treatment. But that's why this treatment, let's say, assess the patient, the indication must be correct. And I show you where we use this CAR T-cell in the patient who relapsed after the conventional treatment or patient having a relapse refractory disease. So that's why we are very strict, where we use this treatment because of the cost mainly. But one thing, what we hope that, with the more research and then we can bring down the cost. And of course, with more competition, now we have 1 or 2, then of course the price we hope can come down. And with that, of course, we always look at other opportunity to engage with other things, like even do a bedside research CAR T, the one that we know the technology, we know the idea, and we need to just be able to produce this CAR T on our own. With the research, I think if we can produce this ourselves, it will be more useful for patient. Yeah. So the cost is not cheap, yes, and it is at least double or triple the price of the conventional stem cell transplant. But that's why we only offer this for patients in need, and we hope that by selection we could select those patients really in need. We use the fund properly instead of trying many cycles of other chemotherapy again, transplant again. But as I shown before, the efficacy is very low if we use conventional methods.
Menarik dokter, dan tentunya untuk Sobat Espos yang mungkin ada keluarga ataupun kerabat sahabatnya yang sedang mengalami ataupun sedang menjalani pengobatan kanker darah khususnya, mungkin salah satu ataupun metode baru dari Parkway Cancer Centre ini bisa digunakan, begitu ya. Bisa langsung menghubungi Parkway Cancer Centre pastinya, dan tentunya nanti ada kawan-kawan dari Dr. Lee yang akan menghandle Sobat Espos yang sedang menjalani terapi ataupun yang sedang menderita kanker darah. Dr. Lee, terima kasih sekali keterangannya, terima kasih sekali untuk penjelasannya, luar biasa, dan sukses terus untuk Parkway Cancer Centre Singapura. Oke, Sobat Espos, sudah Anda simak penjelasan dari Dr. Lee Yuh Shan dari Parkway Cancer Centre Singapura. Semoga saja informasi ataupun penjelasan yang disampaikan oleh Dr. Lee bisa memberikan Anda satu wawasan baru, menjadi satu pengetahuan baru terkait dengan metode yang ada di PCC ataupun di Parkway Cancer Centre Singapura. Saya Nur Atmaja undur diri, selamat bertemu kembali.